The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our LymphCast show, episode 68 tonight. Our topic tonight, Lipedema Uncovered, Stages, Mobility, and the Power of Treatment. And by the way, if you'd like to buy us a coffee to help support the show, we'd appreciate that very much. Just go to buymeacoffee.com/LymphCast Network, and we thank you in advance. Visit our website early and often, lymphcastnetwork.com, and send the doctors an email by writing hello@lymphcastnetwork.com. Tonight's show is brought to you by VitaSupport MD. They make Vein Formula 1000, Lymphatic Formula 1000. Dr. John A. Chuback is the founder and owner. Dr. Gloviczki is here. Dr. Iker is here. And our special guest coming up in a moment, I'll turn it over to the man who started the show, physician, surgeon from New Jersey, Dr. John A. Chuback. Dr. Chuback, take over, sir. How you doing?
Thank you very much, Paul. I'm doing great. Today, it's my honor and privilege to introduce to the show not only a colleague, but someone I consider to be a good friend, Dr. Tom Wright. And, you know, Tom and I met some years ago at a conference and really, again, got along famously, got along like a house on fire, as they say. And, you know, Tom has been really a pioneer in an area of medicine and surgery that we discuss very frequently here on the program, which is this burgeoning and developing area of surgical approaches to lipedema. And, you know, Tom's training and CV are very, very impressive. And I'll just touch on a few points because it's too lengthy to go through all of them. But I like to tease him because he's so smart. He was a graduate of Duke University, which we all know is one of the finest universities in the country. And he's also a big basketball fan, but he did a lot of research while at Duke. He was also a class representative in the student government at Duke. So early on, he was taking on a position of leadership. And he went on to get his medical degree at the University of Missouri Columbia Medical School program. And then as his career progressed, it took what I think is a very interesting turn, and Tom will talk about that this evening with us. He trained in tumescent liposuction. He had an interest in venous treatment, venous surgery, office-based venous procedures, but he was one of the early pioneers and remains, quite frankly, one of the early pioneers in the United States in tumescent liposuction technique for lipedema. And he trained with Dr. Jeffrey Klein, perhaps the originator of tumescent liposuction, and then went for advanced training. To his credit, traveled all the way to Germany to work with some of the originators in lipedema surgery in Germany. So it's really that part of Tom's incredible resume and history as a physician and clinician that I wanted to bring out. And that's what we're going to take a deep dive into this evening. So with that, Dr. Tom Wright, colleague and friend, welcome to the LymphCast podcast.
Wow. Well, thank you. That was quite an introduction. You're really too kind. And, but it's really a pleasure. I mean, I am among friends and I'm really excited and grateful to be here. And thank you so much.
You're welcome. With that, I think that I'm going to pass the baton first off to Emily Iker, because of all of us, she's probably the one with the deepest experience and the most years really focusing on the world of lipedema. So, Emily, why don't you get the ball rolling?
Well, first of all, welcome everybody. Welcome all of our listeners, and a great honor to see you, Dr. Tom. And we see each other at different parts of the world, at some conferences here and there, and it's always inspiring to listen to your presentations, to your work, and all the challenges that you go through, especially with the liposuction technique. And I've seen some of the work that you do, and it's compliments that the outcome is fantastic. And let me ask you, what got you to from a vascular surgeon to branch to this fatty disorder and help all these fantastic women who are with lipedema? As we know, it's still unknown, downplayed, and I get really frustrated when I see insurances denying the treatments and so on. So tell us a little bit more why you start challenging in this branch.
Well, it's really kind of interesting. It is actually kind of personal. I got into veins partly because my mom suffered from varicose vein disease, and she developed a venous leg ulcer later in life. She had retired down and was living down in Florida, and she got really terrible care. She, they thought it was a spider bite and stuff, and they didn't address the underlying thing, and so that's what motivated me to get into veins. And then as I became focused on venous and lymphatic conditions, I began to recognize lipedema more and more, and then sort of like retrospectively realized that was my grandmother had lipedema, and she really went through quite a bit. She developed complications, knee and foot complications from the lipedema, and it just was, to me, tragic because it really kind of hobbled her later in life, and it really, I just saw there was a huge need, and I'm so glad and so grateful that I've reached out to meet that need.
Well, that's wonderful to see some physicians like you to have the empathy and to embrace this pathway in the medical field to help those patients. And I just wanted maybe to repeat some basic for our listener. If you could tell us just a few words how to recognize lipedema and what stages of lipedema we can have.
Yeah. So lipedema is characterized by disproportionate adipose tissue accumulation on the legs and arms. That is internationally, that's how it's recognized. Now, I also believe it occurs on the lower abdomen, and that's it's so it is currently really only well diagnosed or can be with clinical diagnosis, and that is a tenderness and swelling in the legs, and associated with a physical exam, signs of nodularity in the tissue, and then there are certain characteristic physical findings as well, such as cuffing at the ankles, or cuffing at the knee or elbows, or wrists, and then it is also kind of ruling out. So there is lymphatic impairment in it, but the underlying lymphatics, there's no obstruction or absence of structures, which differentiates it from lymphedema, and of course, it also is can be sometimes venous disease can also present with swelling in tender legs, and then but so that's how the disproportionate, the swelling, the tenderness, the physical signs, those are the principal ways we diagnose lipedema. Now, so does that answer your question about what is lipedema?
Oh yeah, absolutely. And
Yeah.
and
it is a progressive disease. It can cause over time. It can affect mobility. And I published, and I just had I might, if we have time, go into a publication about its effects on mobility. But I want to. The other part of your question was about the stages of lipedema, and so that's been so there's some controversy there. I guess there's controversy on everything, but so there is really only 3 stages, and I want to, because I know there's a lot of people in the lymphedema and lipedema world that listen to this, and I want to make the case why there's only 3 stages. And I have the backstory. I have the rest of the story of how there is some people who believe a 4th stage.
Oh, we're getting the backstory from Tom Wright on the lipedema staging controversy. And I'm going to be fascinated to know if Emily Iker knows this story after we hear it.
Well, she knows the players in the story, and certainly. But I'm going to back up a little bit. We're trying to get an ICD-10, the U.S. to recognize an ICD-10 diagnosis for lipedema. And currently, there is no ICD-10 diagnosis in the United States for it, and you have to code it as E68.2, which is other lipomatosis, and it is a lipomatosis, but that's not specific. Or there's also an edema unspecified that can crosswalk to lipedema, and that's R60.9. You don't have to write all this down, but I do actually have. I can't pull up the slides on it right now, but basically right now we can only kind of indirectly code it with on a medical visit or for research, and that's a problem because we need to do research. We need to code this, and so we have been. So I'm working a lot with Karen Herbst on getting an approval for this for the ICD-10, and it's going to be it's going to be basically it's going to stay in the metabolic disorders. Because I forgot to mention, it only affects, almost only affects women, and it tends to be aggravated during hormonal changes like puberty, childbirth, and menopause. And so we are going to get we have submitted, and it's been delayed. Right now, the CDC has canceled all the meetings and stuff. They're undergoing some stuff, and so unfortunately we were going to represent in the spring, but that meeting was canceled. But,
so you have a proposal for the new coding, right?
Yes, yeah. So it would be an E68.23, and but that is on hold, and we're not sure. We hope that we'll be able to address the committee at the CDC in the fall, but that is where we are. But anyway, so in doing the research for that, why we're only asking for 3 stages to be submitted in the coding, and that goes back to when it was originally described by. The original stages were 3 way back, but that goes back about 25 years, and
the original. I think that the first diagnosis was done at Mayo Clinic, I believe, right?
Right. Yeah. So Edgar Allen and Alan Hines were wrote the first paper. It was right around 1940, that they at the Mayo Clinic, and they described lipedema. Initially they didn't ascribe stages to it, but later on stages were ascribed, and then in the so about 2014, Karen was over in Europe, and she saw a poster that maybe said a stage 4. There are, basically in the original description, the thought was stage 1, where the lipedema tissue is smooth to appearance, but you may feel the nodularity. Not stage 2, there is dimpling of the skin. You can see skin irregularities, and then stage 3 lipedema would be with the with lobules, which are extrusions of fat tissue that extend outside of normal boundaries, like the thigh lobules, or what some ladies call saddlebags, etc. These so those are the original 3, and then Karen in a paper mentioned there might be a stage 4. Well, that just went. Then everybody's talking about a stage 4, but there really wasn't any clear basis. Originally, stage 4, people started saying, well, maybe that's when you have lymphatic impairment, but that's not true, because lymphatic impairment can occur and does occur at all 4 stages, or all 3 stages. Sorry, caught me up. And so by stage 3, 60% of women have lipedema, have lymphatic impairment. And so the original description for the stages was the shape, the phenotype you see, the shape you see, and it's confusing to try and add in lymphatic impairment, which can obviously you can have lymphedema at any stage of lipedema. And so stage 4 masks the actual diagnosis of lipedema. And so that's why, and plus it's just better to keep it simple. So 3 stages, and the stages describe the phenotype, and lymphatic impairment can occur at any and all of the stages, and so there's not really a stage 4 was supposed to include when there's lymphatic impairment, but that's really not accurate. So that was a long way to go to explain the stages of lipedema.
Yeah, and I think that one of the other things which is a bit confusing is that Dr. Wright did a very nice job explaining the various stages of lipedema, but then there's another subject, which is the quote-unquote types of lipedema, which is another subject altogether. Tom, do you want to take that a little bit about the
Sure. I mean, but I feel bad. Emily could. There's 5 types, and those
don't feel bad. Emily's one of the hosts, not the guest. This is your moment.
Okay, all right. Okay. So type 1 is just involving the hips. Type 1 is hips and thighs. Type 3 is hips, thighs, all the way down to the ankles. Type 4 is in the arms, and type 5, really the rarest, is when it just affects the calves and ankles.
Right, and I think that was a very important thing to go over. That's sort of your kind of, as you mentioned, phenotypical type, where how the disease is affecting the anatomy of the patient versus the quality of the tissue itself. Whether it's subcutaneous with smooth skin and nodular skin, lobular skin, or lobular demonstration of the fat. So it is a little bit confusing that there are these stages and the types. So for patients who might be listening, or people who think that they may be a patient who may be suffering from this problem, you want to look at yourself, and you want to look at both the types and the stages. And then when you go to see a physician, you want to be well armed with that information, because sadly, a big reason we still have this program is the vast majority of the physicians that you'll see in primary care, et cetera, will have no idea what you're talking about and try to dismiss you, quite frankly, as just being overweight. And one of the things I think that's also important to point out is that not every obese patient has lipedema, and not every patient with lipedema is necessarily obese. Would you agree with that, Tom?
Oh, for sure. Yeah. And we, there's clearly, so obesity can be a complication or a comorbidity, but there's a large percentage, probably 20-25 that are completely normal weight. And I've actually had published a paper about a couple patients who had anorexia nervosa, were actually underweight and had lipedema.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
That's fascinating. One of the things that I point out to my patients, and I'm sure that everyone on the panel and Dr. Wright has seen this, which is helpful, I think, in instructing other physicians, but also in reassuring the patient that it's, as we like to say, quote unquote, not their fault, is that so often the typical lipedema patient tends to be very, very tiny in their torso and in their trunk. And then, the lipedema is, as you say, very disproportionate to the rest of their anatomy. It's not that most patients don't have a very large protuberant abdomen and so forth. So that's one of the classic telltale signs, I think, especially for physicians who are new to this subject matter, when you say, boy, this patient really does look so little in the midsection, and then so out of or disproportionate anatomically with especially the lower part of the body. But as you said, it can also affect the arms and the upper extremities. So I think that's important. I bring it back to Emily and Monika for any more questions for this wealth of knowledge that we have with us tonight.
Right. I just want to point out about the lipedema, the difference between lipedema and lymphedema when you feel the tissue consistency. Lipedema are very soft, squishy, mushy. I call it feminine, and very sometimes very painful to touch. And a lymphedema, on the other hand, lymphedema is quite firm, especially long-standing lymphedema. The tissue consistency is very hard. So that's the difference. And in terms of the arms, the type 4, it says arm involvement only. But when you do the clinical examination and combine it with the ultrasound, I've seen also type 1, type 2, type 3, and the arms were involved as well. So it's not only the type 4. And as many patients as we've seen, and Dr. Tom as well, there is not one identical to the other. There are so many different shades of gray, and it blends. But once you have coughing, that's typical stage 3, where the lower extremities are like piano legs or tree trunk legs and so on. And even though I have been in this practice for 30 years now, I have seen only 2 patients with type 4, where only type 5, where only the lower extremities were involved, and the patient was so slim, but the only thing she had a problem with to fit into the boots, and she had the pain in the legs below the knee.
Right. Just for our patients, I wanted to specify that's what Dr. Iker means. From the knee down, that would be the type 5, which is very, very, very unusual.
Rare.
But you frequently see just the lower extremity, meaning from the groin down. That's very common. And I agree with you, Emily. I think that the type 4 patients that I see almost invariably have some element of type 1, 2, or 3. The lower body is almost always included. I don't recall seeing, now you may, but I don't recall seeing any patient with isolated upper extremity lipedema with a completely normal lower body morphology.
Correct. Very, very much so.
Yeah. So I actually those are great points. And I actually, if they're really only in the top, I think of other lipomatoses like Madelung's disease, which is affects or multiple symmetrical lipomatosis, which affects just the upper body. So
that's a great point. Very, very, very interesting.
So now the big question that is very, very often asked as a first question by the patients, can you starve or can you influence with diet the lipedema?
Yeah, that's a great question. And I have, I just published, this is in collaboration with Washington University School of Medicine and St. Louis University School of Medicine. We just a very comprehensive diet, weight loss and diet study on lipedema patients. And I can describe it, and it's probably quicker if I just describe it, but I do have some slides if you want me to share. But so basically, so this came out it was just December of this last year that it was published. We looked at women with lipedema, and then and compared them to BMI, age, and sex matched controls. So and then we did they went through MRI scanners, DEXA scanners, and very sophisticated metabolic testing, including a hyperinsulinemic glucose clamp, which is the most sensitive. It's real-time insulin and glucose measurements the most sensitive way to measure insulin sensitivity. And so, and then that was the roll in, and then they went on a prepared, metabolic lab prepared meal replacement using a modified Mediterranean diet, basically, and they accounted for calories as well as micro and macronutrients. And they were on this diet till they lost 10%, about 10% of their weight. And so they re-looked at these, at the body composition by the DEXA scan and MRI, and they re-looked at the metabolic differences. And so compared to the BMI matched controls, the women with lipedema had disproportionate accumulation of fat mass in their legs. So basically, these studies, the MRIs and DEXA scans confirmed that it was disproportionate accumulation, and that the specific number was 23% greater fat mass in their legs compared to the controls. And then as they went through this diet, the women with lipedema, just like their BMI matched controls, were able to lose weight in about 10% of their body weight. And they lost fat mass. They lost about 10% of the fat mass in their legs with that. So now the proportion, the excess 23%, in fat mass in the legs persisted completely. It actually didn't change statistically, but it was actually slightly increased as they lost weight. So they basically they lost in on all their areas, but their relative disproportionate did not change. And so what does that tell us? That tells us some really interesting things, and really important to share this around is that diet does have an effect on lipedema. In fact, the host, Dr. Iker, has a great book that I still recommend to everybody about how a diet that is helpful for lipedema. It's again avoids refined carbohydrates and is anti-inflammatory, and that's what I recommend for my patients and what they were on. So they were able to lose weight, and they were able to lose some of their fat mass in their legs. That's really, I think, important. I mean, there was a lot of other things we found is that I talked about the metabolic testing, and so the lipedema ladies were more insulin sensitive compared to their BMI matched controls. So they were closer, even though if they had an elevated BMI, that they were more insulin sensitive, like someone who is lean. And that when they lost weight, they got even more sensitive, insulin sensitive. But there are other.
I think that's a really fascinating point, Tom, that it tells you that the whole physiology of the individual is different. You're not necessarily looking at a metabolic syndrome type patient just because they have this additional fatty tissue, which is, as we now recognize, a fat disorder and an abnormal kind of fatty tissue. So that insulin sensitivity is quite interesting, so that those patients could be considered, generally speaking, healthier than a typical obese patient. The other thing that you got me thinking about, you had mentioned a couple of patients with anorexia nervosa who had some element of lipedema, especially the type 5, it sounds like, from the knee down. And you wonder, in a patient like that, because of this study that you just are publishing or have published, you wonder how much of that may have been the incentive psychologically or emotionally for those patients to develop anorexia, because they have this disproportionate fat distribution on the body, and they're thinking, if only I could lose 5 more pounds or 10 more pounds, I could fix myself and I could be normal. And here they've become, so those patients in a way kind of already showed what your study has proven, which is, yes, you can lose a lot of body weight and maybe even make those areas of the body a bit smaller, but that disproportionality is going to persist.
Yeah.
Or being even more pronounced.
Yeah, exactly.
So, right.
Yeah. I mean, that's right on. So they exactly in fact, in the publication, the case patient we reported that her large thighs and calves made her self-conscious and feel as though she needed to restrict, and she became obsessive about trying to lose weight and diet off these larger legs, and then because of that developed unhealthy eating, developed the full diagnosis of anorexia.
Yeah, and it's the other thing that you brought to my eyes. I had the pleasure and the privilege of seeing Dr. Wright present not too long ago in Florida at the Independent Vein Practice seminar, and he talked about some of his experience with the GLP-1 drug in these patients. And Tom, you can speak to your experience with the GLP-1s in lipedema, and so can Emily. But now it makes even more sense to me, in addition to the tissue being different, but the fact that they are not insulin insensitive, even makes more sense why they don't lose weight the way other overweight patients do, because those other overweight patients, whether or not they're truly obese, they probably have a greater degree of insulin insensitivity and metabolic syndrome than these patients, which explains partially why they're not responding the same way to treatment.
Yeah, for sure. Yeah. So it was really, this is really important that we did. It's long been. We've always thought the fat accumulation in the legs was sort of cardioprotective, but this really kind of puts numbers in ability that insulin sensitivity in the relative metabolic health of women with lipedema. Yeah, and I think that's really important that we emphasize that.
Emily, I do want to let you chime in on.
Yeah, I want to point out that all my consultation, pretty much all my lipedema consultation patients, I send for allergy testing. And numerous cases I had when the patient said, it's heartbreaking because I am on such a strict diet, etc., and I cannot lose weight. So and she said, I eat healthy, I eat only Mediterranean salads and chicken and so on. So I sent her for allergy testing, and she was highly sensitive to lettuce, highly sensitive to garlic, highly sensitive to celery, and which you would never think that someone can be highly sensitive. So as a reaction to that, she was bloated, and she had gas, bloating, and all the GI issues. So again, every patient is different. And so we have to look at them, not only what type and specification you have. We have to look at the whole picture, what is going on with this patient. And the allergy testing and sensitivity may give us also clue about the metabolic problems.
Absolutely. So, and I have the question maybe for all of you. I think that's an important point that you were saying, that actually you have the, in some regards, you have the metabolism, specifically glucose metabolism, which is perfectly normal, and some other stuff is normal. But I think that this disease is not only about cosmesis. So it's, I mean, that beside the fact that glucose is normal, these patients, because of the, maybe because of the issue of mobility, and you will tell us something about it certainly, are prompt to actually have the long-term complications of the disease. So let's talk about this. Why? Because if we consider that it's the glucose metabolism is normal, everything is normal, why should we treat them? You see?
Well, that's a great question. So right, this disproportionate fat can affect gait, mobility. It affects on most of my I get out my orthopedic goniometers and measure angles, and they almost all but the smallest. It affects their angle of their knee, their hip angle, their gait, and so that's early on. As they progress in stage, and certainly they get more mechanical stress leads to a higher rate of knee arthritis and knee failure. They have a high rate of total knee replacements. It's like 4 or 5 times the average rate. We measured then we measure. So we use these measurement tools on their gait and mobility. I measure the knee range of motion, and it's quite restricted, and that affects your mobility going up and down stairs. And then they have the bulk, the tissue, and the secondary orthopedic complications then further affect gait and mobility, and so they walk at a slower speed. They're the average lipedema patient coming in. So we use the PROMIS Mobility, which is a NIH toolkit validated assessment of mobility, and it's normalized to the population. And so 50% would be average in the population, and they come in around 30%, 35%. And then we looked at, and the intervention we looked at would be this lipedema reduction surgery, a specialized type of liposuction, and that significantly improved their mobility. It improved their knee range of motion. It improved the mechanics of their joint alignment. And these are powerful things, because that decreased mobility is associated with shorter lifespan and in future disability. And then and same with ascending stairs. I mean, these are simple tests, like so they reported on how well they could ascend and descend stairs, and that improved significantly.
These are all incredibly important things. Tom, the skeletal, orthopedic, functional, occupational kind of therapy concepts, all obviously incredibly important. The thing that we talk about on the show a lot, and I think I bring it up a lot, is also obviously mental health, how it affects mental health, psychosocial and emotional status of the patient, psychosocial and sexual status for the patient, depression, anxiety, a sense of helplessness, embarrassment, guilt, shame. I mean, it goes on and on and on. So even, Monika asked a great question about, well, if it doesn't affect your blood sugar and you're not insulin insensitive, well, why should insurance companies, the federal government, and others see it as a real medical problem? Well, you listed a dozen great medical problems, and I think that this country in general has to stop forgetting that the mind, not so much the brain. I've written a lot about this subject. The central nervous system as a electrochemical switching station. That's great in terms of typical brain function, but we also have a mind and emotions and feelings that make us different from all the little animals in the world. And those feelings and that aspect of humanity is a very, very important part of health and wellness and well-being. And we have to stop dismissing it in this country. So people like you are doing something great, and Dr. Iker, but you touched on something, Tom, I want to give you the opportunity to talk about, because remarkably, we're getting closer to the end of our time, and the show is better than I even had imagined. But talk to us, for our patients listening, physicians listening, surgeons listening, maybe some plastic surgeons listening. In your opinion, how does liposuction for lipedema differ from traditional cosmetic liposuction, or does it? And if so, how and why is it important?
Yeah.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Great question. So, by the way, we also did look at those we looked at quality of life measures, including emotional well-being and interference with doing your job or social functions, and it did improve with the surgery. And we were one of the first to look at that. So, but to get to your question specifically of how the liposuction for lipedema is different, first of all, it starts with the goals. The goals are to improve function, mobility, decrease pain. It's a larger volume, so a cosmetic liposuction is only going to actually wants to take only the ideal amount to get the best cosmetic result. A nice cosmetic result is good, but the goal is to relieve symptoms, and we take as much out as possible, and then there is impairment in the vast majority of lipedema patients, lymphatic impairment, and we take great care to not so there's always going to be some disruption of lymphatic vessels during liposuction, but we take care to not injure the principal lymphatic collectors, and so I map out them before the surgery, and so my technique then is to not transect them or go against the grain, because there was a nice set of studies showing that the lymphatics vessels these collectors will tolerate longitudinal stressors over them, but are more susceptible to transverse stressors. So all that is baked into how we do the surgical approaches for each of the areas, and so again, so we get different outcomes.
Are the cannulas any different? Is the equipment any different?
So I use smaller cannulas. I like those big basket cannulas and all that. Those are more traumatic, and I avoid those. And as well, I use. I'm very generous with my tumescent, and make sure it's the area is fully tumesced. And then I use small blunt cannulas. But many cosmetic surgeons do use small blunt cannulas, but many also do. Yeah.
Is there any additional benefit in your experience or opinion in laser-assisted liposuction that I've heard of?
Yeah, I am not a fan necessarily of adding energy devices, because I just am my concern again about lymphatic injury. And there's a little, adding rarely I will do Renuvion, which is a helium plasma kind of energy device, but I usually just do that in the arms where I'm going to be honest, I'm not really seeing as much lymphatic impairment in the arms as I do in the legs.
I have one more follow-up question. We had the privilege, thanks to our dear friend Emily Iker, to have on our show Dr. Håkan Brorson, who
yes,
I'm sure you know, who showed us remarkable before and after pictures of patients that he has treated with lymphedema.
Yes.
And I wonder, with your pioneering spirit, Tom, have you considered taking on any of that kind of work, and have you done any of that work?
Yeah, I have. I have treated people with lymphedema and lipedema that have lymphedema and lipedema. And that's with basically milder. I don't do the big debulking on the lymphedema affected legs, but I do. I will treat women with lymphatic impairment and lipedema. It's got to be like, once it becomes just totally calcified, just and grow and like this stage 2+ stage 2 or I shy away from that. I refer those to other surgeons, but I will treat with mild lymphedema. Yeah.
Very good. Very good. Well, I think we're coming near the end here. Emily, do you have another question or two as we close things up?
I think we can invite Dr. Wright again, and we can talk about lipedema and pain, lipedema of hypermobility, and all the other issues which are part of the lipedema. And so it's not only disproportionate enlargement of lower body, but a lot of other issues. Right. And pain is very, very important factor in lipedema, because whether you have stage 1 or stage 2, stage 3, they all suffer from pain.
Yeah.
I'm sorry. Before we end, I have another question.
Go ahead, Monika.
Yeah, I'm sorry. So, because of this association, you have lipedema, lymphedema, you have some, as you say, the lymphatic impairment. Does it make sense for lymphedema patients to have a compression therapy and some pumps or compression?
Yes. So everybody, not only diet, but also everybody with should be wearing medical grade compression, and many benefit from the pumps. So I will. It's actually crucial, and especially I won't do surgery if they won't be compliant with the compression stockings, the compression pantyhose, basically. Yeah.
So within the treatment, you always consider the diet, of course, compression, and liposuction for some group of patients, right?
Yes. Yeah. And then other things that we do sometimes is we do recommend the lymphatic formula for our lipedema patients, and as well as manual lymph drainage and
compression pumps.
Yeah, compression pumps. And then I also have started and found some success with using the GLP-1s as well. But I don't want to, I know we're getting over our time, so I'm just going to, but that to me is comprehensive or holistic treatment of lipedema. And it really, there's no cure. There's none of these cure this. So it really has to be done comprehensively to get the lifelong improvements.
And you do consider that indeed with this approach, you have the clear medical benefits and improvement of life expectancy and decrease of disabilities, certainly.
Yeah. So we I can get into this further at another meeting, but basically we looked at the same measurements that they use. So this PROMIS is used across all diseases, and it's highly validated. We looked at that, the improvements we see with that, as well as the knee mechanic improvements and the decrease in pain is actually equal to or greater than what we see with total knee replacements or other orthopedics procedures. So it's really a value because you get so many benefits that are even, and think of all the money we spend on joint replacements.
Yeah. But
you can head that off. You can prevent that if you treat their lipedema early
Yeah, I would. The other thing I would add to that, is that, we had a very special guest, Tom, who you should know. I should introduce you personally, Dr. Barry Franklin. Right now, I think he's doing a 1 month teaching sabbatical in Shanghai. But Barry was up in Detroit in Paul Reeves' neck of the woods at Beaumont Hospital for many, many years as a physiologist, exercise physiologist, running the cardiac rehab program. And, just this business of mobility, I shouldn't say just, I should say the very important subject of mobility and walking and ambulation, we now know the data is clear. This has a very, very strong correlation with survival and with early death. So if you can get these folks, even though they're not, metabolic syndrome patients or insulin insensitive, et cetera, if you can get them up and moving, we know that there are many, many reasons why that has a very, very positive impact on survival and quality of life, but especially, not especially, but let's not forget survival. That, we like to say sitting is the new smoking. It's really, really bad.
Yeah.
The other thing I would just throw in at the end, for physicians listening, patients as well, we see these three problems often together: vein disease, lymphatic disease, and fat disorder. So often I see in my office lympholipedema, and so forth. So often it's a combination of problems. You need to go to a really, really qualified individual like Dr. Wright, who is going to evaluate your venous system, your lymphatic system, and your adipose tissue to give a full and comprehensive diagnosis so that a full and comprehensive treatment plan can be put together. And I think the last thing I'd like to ask Tom and Emily to opine on, because we touched on it, but again, for patients and physicians, lipedema, I often think of as a bit of a misnomer. I think it's a little bit of an unfortunate name because the edema part. And many times lipedema patients don't have demonstrable pitting edema, et cetera.
Oh, yeah, right.
Lymphedema patients will, et cetera. So talk a little bit, if you can, about edema, true swelling in patients with lipedema versus lymphedema.
Still them. Okay.
Can I go first or you go first, Emily? Which?
Well, I have to run to the patient. So go ahead. And I'll.
All right. So we do see non-pitting edema in almost all my lipedema patients. And basically, so people only think of edema as in terms of pitting, but edema can also affect the skin texture and turgor. And even so, they're usually soft. But if you do what's called the Bjork test, which is where you pinch and twist the skin, or bow tie test, I can demonstrate non-pitting edema in almost all my lipedema patients, and then I can confirm that. It's not just I see that also. I do bio.
Tell us about that, Tom, for a second. What is the result of that test? What is the clinician looking for when he does the Bjork test?
I'm gonna do it here in my thing. So So you can pinch and twist the skin. So you can see that's normal. You can pinch and twist. If you can't pinch and twist and create that bow tie, then there's edema in that tissue, and that correlates well with measurements of extracellular water on bioimpedance. Right. And so,
well, Tom, if I can interject, I do the ultrasound, and with ultrasound, you clearly see the difference between lymphedema and lipedema. And again, we need you back so we can go and talk more about this, what the changes we see on the ultrasound. And there is a clear difference between lymphedema and lipedema. And it's not so much the pitting, it's the soft tissue consistency. It's so soft, so squishy, fluffy. And I would say sometimes you think that the connective tissue is so loose that it gives you the appearance of the lipedema, then pain is enormous. Even in stages of 1, you may have a stage 1 with enormous pain according to the inflammatory changes that the patient has. And mobility is, as you pointed out, hypermobility, center of gravity is completely shifted in these lipedema patients. And they may look nice, but they are completely different. And it is misdiagnosed even today. Unrecognized condition. And most of the time when the patient and physician does not know about lipedema, then they, and many times I said these patients, they were sent to see a psychiatrist because they said it's all in your head. And it's not true, because these patients do suffer greatly and they are very careful what they eat, and they don't overeat, and yet they cannot reduce the lower part of the weight that they have. So it's not only that, but also psychological aspect. And we already touched upon that. So it is downplayed, ignored, and misunderstood diagnosis.
Yeah, I just want to add circle back to what John said, just real quick, but there's also a controversy whether there's any edema in lipedema. And that's really, in Europe, there's a controversy over that. But to me, there's no question that these tissues are edematous and swollen, and they experience the swelling. The swelling gets worse towards the end of the day. Their ankles swell horribly, and there are people in Europe who say, oh, there's no edema in this, but that really, and then on the exam we can see it on bioimpedance, and then Shelley Crescenzi did some MRI studies that show increased tissue sodium, which is a marker for swelling in these tissues. So there's no question in my mind that there is edema is part of and a component of lipedema.
And so
true, Dr. Marina Cesari in Italy pointed out on her ultrasound, and it was the megahertz of 70 high frequency ultrasound. She clearly demonstrated a fluid component in the lipedema patients a few years ago, and it is documented. So it is there.
And so compression should be valuable under those.
Absolutely.
For sure, yeah.
Yeah, the reason I want to bring it out is because many people do not recommend compression for lipedema patients because they tell them you don't have any edema, it's just fatty tissue. So I think that's a very important subject to clarify.
Thank you. Yeah. And it also, as you know, compression also has an anti-inflammatory effect too. So it, that and helps with the pain. But yeah.
Wonderful. Well, I think that is a great place to wrap, and it gives us a perfect excuse to invite Dr. Wright back. And Paul, I'm going to give it to you to bring us out.
Sounds good. Another great show, heavy on content, but I'll tell you, as a non-medical person, very understandable by the non-medical community as well. So great job, and hats off to everybody. We want to invite everybody, buy us a coffee. Go to buymeacoffee.com/LymphCast Network. We thank you in advance. Tonight's show has been brought to you by Vita Support MD, makers of Vein Formula 1000, Lymphatic Formula 1000. Visit our website, lymphcastnetwork.com. Again, tonight it's been our LymphCast show, episode 68. Let's thank everybody and head for the hills. Dr. Gloviczki, thank you for everything. We'll see you next time.
Thank you for having me.
Always. You better be here every single week. Dr. Iker, thank you as well.
Thank you very much. And we hope to see you back, Dr. Wright, and continue our discussion. And I'm sorry I have to run.
Yeah, thank you so much. It's been a pleasure. And I really appreciate our discussions.
Dr. Chuback, would you like to take the honors of officially thanking Dr. Wright?
Absolutely. Dr. Thomas Wright, I want to thank you very much for being our guest on the LymphCast podcast. It's a great pleasure to have you. You're an inspiration and a trailblazer. And the last thing I'd like to do is ask you to share with our listening audience where they could contact you in case they might be interested in seeing you about lipedema and possible lipedema surgery with liposuction.
Yeah, so I have a website called lipedema.net, if you put in lipedema, it often comes up. And then I also have some social media, Instagram and LinkedIn, and a very vibrant YouTube channel. And it goes by either lipedema.net or Lipedema Surgical Solutions. So yeah, those are those are my handles. Yeah, thank you again.
Of course, I'm sure that you're going to hear from a lot of our listeners, because we have a vibrant community following us, and it's very few people doing what you do, and with the expertise that you have, and having taken this very important field so seriously. So thank you once again for that.
Oh, thank you. Yeah. Well, that's thank you. That means a lot.
All right. Thank you. And let's also thank the founder and owner of this show from New Jersey, physician surgeon, Dr. John A. Chuback. Thank you, Dr. Chuback, for everything.
You're welcome. It's my pleasure. As always, I think I learned more than anybody on my own show.
Yeah, this was a great show. You're a great note taker, so I know you'll be going through those notes in the next few days. Right. And again, our LymphCast show, episode 68. Have a great night. We'll see you next time for our LymphCast show.